of Know Your Calling. So here we have Dr. Saurabh Dixit sir, who is one of the most renowned surgeon in our country. He has done his MS General Surgery and Diploma in Minimal Access Surgery, Fellowship in Minimal Access Surgery, and Fellow of International College of Robotic Surgery. Hi sir, welcome to our team.
Thank you. Thank you.
So we're very
Always
honored to have you here for this interview.
a pleasure for me also, always talking to young medicos.
Thank you so much, sir. We were always looking forward to have you, and thank you for sparing us some time and giving us your valuable time.
My pleasure.
So first, can we start with a general introduction of the branch, sir?
Yeah.
So, coming to general surgery, can you just give us a small introduction about what is general surgery and what all do we cover in that as a postgraduate branch?
When we talk about general surgery, it's a broader perspective because general surgery as a term means everything. So you get acclimatized to basically the attitude of a surgeon. You get acclimatized to the branch where you learn the basics involving everything, right from a small minor procedure up to the complex surgeries. So when we talk about general surgery, we start with right from the minor procedures and we go up to the most complex procedures which are being done. So it's a broad perspective where nothing can be justified. It's just like it's a seamless horizon. You can look anywhere, everywhere you want. It's up to you how you want to pursue your 3 years. Let me tell you, in this phase of general surgery, you get acclimatized to surgery also and to super specialties also, because there's a rotation, compulsory rotation in your second, you can say, year of residency, where you go for 1 month or 1.5 months of rotations. So always remember that is the most crucial time of learning basically. When you talk about general surgery as a whole, there are a lot of students who think that we will learn to cut. Basically, we will learn to operate on a lot of things. But actually, this is not true. You learn what to cut, what not to cut, and when not to cut. These are the three principal things that we actually learn in general surgery. General surgery is to understand how this branch goes, how to deal with the patients, how to deal with the basic scenarios like lap cholecystectomy or appendicectomy or hernia surgeries or breast cancer surgeries or thyroid surgery. If you see in a broader perspective, when you go for MCH gastro, surgical gastro, or suppose you go for oncology, MCH surgical onco, what happens? You are doing that same thyroid only. You're doing the same head and neck only. So basically, MCH is more about sharpening the skills with the system, whereas surgery is a broader perspective where you introduce yourself to that system.
Thank you, sir. Thank you, sir, for that information. So coming to the residency in general surgery, what is basically a life of a resident during the life of a resident while doing the residency in general surgery?
The first thing that I will say, very particular about the scenario in India, welcome to hell, basically. The first dialogue which I still remember when I entered into the residency that day, I was very happy because that first day I was stepping into the shoes of a surgeon. But the very first dialogue which I still remember Dr. Partha sir has told me that welcome to hell. I said, why sir? He'll say, you'll realize over the time, but students take it, this hell is going to lead you to the heaven. Remember, this is a hell where you have to practice. You have to practice. There is no excuse. Like in MBBS, we used to excuse ourselves from the ward duties or ward rounds and everything. And we used to think that, okay, nothing will happen. But here, students, the more you burn yourself, it's, the process of annealing iron, which is tempered, heated, cooled, and then we actually generate that strength of iron. So more you spend the time in your surgical residency and more smartly you spend, that is going to decide how well you're going to do in your later days. Like we always keep on complaining. There are a lot of students, and one student recently texted me on my Telegram group also. Sir, recently I spoke to one of my friend's father who is also a doctor. He told me don't take surgery because first of all that learning phase is long, and then when you complete it, you will have to be slaughtered at the end of the, you can say, physicians which are going to ask for the cuts and demands, the payout. So that is everywhere, 20%, 30%, 40%, 10%, whatever is there. And or you get exploited at the level of corporates. Students, I want to tell you that why you took surgery. Was it solely a financial gain? No. Why you took surgery? Was it solely, you can say, a brand of a surgeon that you wanted? No. It was just because you had that pleasure of burning yourself with that branch. It was the sense of perfection that you got when you actually stepped into surgery for the first time. It was a sense of completeness that you get when you become a surgeon.
The job satisfaction sort of thing.
I also joined surgery. I never regretted it. And at a very young age, now I'm having two hospitals and a lot more things and hotels, etc. Everything that I have built up is with this surgery only. So there is no end to perfection. If you are perfect in your job, there is no competition. You'll create your way out. So don't think that this branch is saturated. Every branch is saturated. Talk to me. Even if you go to a NEET PG entrance or a NEET UG entrance, the teachers are saturated. You go to a mall, there are 10 malls, they are also saturated. You go to a shopkeeper, they are saturated because there are 10 shops coming up and they have to fight with e-commerce giants also. If you talk about engineers, their jobs are getting saturated. Every day they get loaded with the work, and if they're not able to perform. So why are you taking these excuses? You wanted to be a surgeon, that is why you took surgery. You wanted to look into the world from your eyes of a surgeon. That is why. So young people who are actually refraining, I'm sorry about my sore throat. So young people who are actually refraining themselves from joining surgery just because it's a competitive branch, that there is a lot of endurance required and me time is not there, you time is not there, whatever times you say. But let me tell you, this is a religion. Once you start following this religion, you'll find solace in that pain also. In that sensation of, you can say, adrenaline gush that you get, you can only feel, you cannot explain when you do surgery. So I took surgery because I wanted to be a surgeon, and this should be the single-handed explanation for everything. Everything.
Okay, so thank you, sir. Thank you, sir, for that. What is one of the basic doubts which most of the students have is like, in each year of residency, how is it? Like, are all the years the same, or is there any gradation in the workload or the work-life balance as each year of residency progresses? So, can you just give us some idea about that, sir? Like, of 3 years of residency?
Definitely. Actually, the residency is divided into basically 3 years.
Yes,
And these 3 years are designed to mature you. Basically, in the first year, we think that, oh my God, what work we are getting? We are doing only file works and this and that. We keep on doing minor OTs and we keep on assisting in dressings, basically, or doing dressings. And keep on working hard with the files and a single error. And then they used to sit us again for that whole night and complete everything and then write the things again. Do you know, this is an important thing? And that is why the first year is conditioned like that. Because if you don't know the paperwork, there is nothing known as verbal communication. When you step into the word as a surgeon, your OT notes, your way of handling the patient will be reflected in terms of the orders that you have given on the papers. And that is why I think that is the first step that should be taught before handling a scalpel, because a scalpel can be bought and used by everyone. But the attitude to handle that scalpel should be given or should be acquired over the time. So yes, in the first year, you get to learn some basic procedures, and yes, you get to see enormous things. But one thing is there, that you have an excellent workload. And students, let me tell you, the more the workload you handle, the more you learn the discipline of this branch, because you'll not understand this right now. But when you'll become a consultant and you operate on a patient and the patient has a biliary leak with peritonitis, my God, you will get a call from the hospital that 20 people are standing out and how to handle. Now, you have been a sugar baby. You have been just cuddled and pampered over the time. So now how will you handle that thing? How will you handle that pressure? So first thing is to mature your attitude that are you fit for the surgery or no? That is why many students leave this branch in first, or you can say 2 months, and then they opt for anything else. So yes, you are taught the basic discipline of this branch. Along with that, the ward works. When you go to the second year of the residency, basically you start getting exposed to more and more specialties, point number one. And the second thing is that more and more emergencies are available, because The third year residents are not available in the emergency because they have a time running on, everyone in medical college. We start studying at the 11th hour. So for them, the time is now, you can say, do and die scenario. So they are not there in the emergency. Then you start getting the anastomosis, basically perforations, maybe hemicolectomy. So that is the time when your hard work, you reap the fruits of your hard work which you have put in first year. Because if you do good work in first year, you maintain a good rapport in front of the consultants, and they know that this guy is there, he can handle this thing. Your SR knows that he will be able to handle, and then you start operating on the patients, and that is for the first time when you actually get acclimatized to the life of a surgeon. Because when you're operating as a S1, then only you know the level of responsibility that you have. When you're S2 or S3, you keep on looking here and there because you're not interested and not directly involved. But yes, when you're S1, that is the time when you learn that 200%, not 100, 200, by your concentration or your assistant's concentration should be there on the skin or on the camera if you're going for an endoscopic surgery. So second year, you get matured enough to learn the skills. And then third year, you sharpen those skills. Basically, in third year, you start doing good surgeries. This is not confirmatory. This depends upon two things: the department you have, the institution you have, the loads that you have, and how willing are you. So what happens in third year? This all depends upon how well you have matured yourself in a couple of years, what kind of info you share with your professors, APs, and because they are the one who will give you the big cases now. Because 30 is the time that you will be needing some good cases, like you want to do a gastrectomy, you want to do hemicolectomy, you want to do APR, LAR, you want to be an S2 in surgeries like Whipples. Like, because my thesis topic was Whipples, so anywhere the Whipples used to happen, I used to scrub it. And many students used to think that it's a 6-hour surgery. It's good that you are there in this phase of 6 hours. But actually, I actually concentrated on that part because that is the time when you actually learn the skills. No one is going to teach you, hold your hand, abuse you, and make you learn the things. This is only during the third year of the residency when you sharpen those skills. And that is why that is the most important phase of your life, when you actually mature yourself as a surgeon. You started as a surgeon in second year, but you matured yourself as a surgeon in third year, because we often see that after the APs and SRs, it is the third year who is actually controlling the things. He's the one who is deciding everything, who is planning for everything, and he's the one who is actually responsible for the complete unit. And if anything goes wrong, he has to answer in front of the professors that what is. So, a real surgeon-like feel that you develop is in the third year of the residency.
Okay, sir. So that was like a very honest point of view from what you told us right now, and you just made us all realize that there's no shortcut, for being a surgeon. Like, you have to go through the hard and cut process to find yourself as a surgeon, isn't it? Sir, like, this is one more doubt which students have is, like, is there any particular, like a behavioral trait or something which a person must have to pursue surgery? You told us that discipline is necessary. Other than that, something else which a student must have in order to pursue surgery, like any specific trait or personality or something? Like,
first of all, you should be, you can say, empathetic towards the patient. That factor of empathy is very important. Why? Because many a time it will be like you are busy with the work throughout the day, and then at 2 a.m. you can say midnight 2 a.m., you get a call that there's a patient. So if you don't have that empathy factor for the patient, you'll never be ready to go to the hospital. You'll be reluctant. Like yesterday, I'll tell you about yesterday's scenario. I was very busy. I had a surgery in the morning, and then I had a test and discussion of my institution in Delhi. And then I came to my place at 10:30. And then at 12:30, I hardly had just catched or gone into a nap phase. Then I got a call from one of my friends that his brother is seriously ill and he has to come to the hospital. No, this is not my case. Actually, they were thinking restlessness and respiratory distress, and they have tried a lot of, you can say, physicians, but no one was picking the call in that. Now, me being a surgeon, we acknowledge that these things, that post-operative, there could be a patient of cardiac arrest and where to find, and by the time we'll find a cardiologist or a physician, the patient will go. So being a surgeon, we learn the basic etiquettes of a physician also. So at 12:30, I got a call. I arranged for the ambulance driver. I called him. and asked him to come into the placement. I arranged for an assistant, and then I myself came to the hospital at 1. Couldn't save the patient. At 2:30, the patient died. But up till that time, I was there in the hospital. So it was not my case. But actually, I have learned that basic thing from this only.
Okay, so that's some point which everybody should understand and follow. Sir, can I move on to the next question?
Yeah, yeah, yeah.
So, other one of the other like a confusing factor or something which not everybody talks about is the settlement factor in each field. So, coming to general surgery, like what is the average years that a person requires to settle in the career?
The incubation period, what I would say, is 5 to 7 years. Basically, it takes 5 to 7 years minimum to acknowledge yourself. Why? Because in the initial 4 or 5 years, you might be handling the patients well. But these patients are the patients, and this reputation is the reputation which will revolve and will come back to you. So the day you start getting the first round and second round of referrals from the patients whom you have already treated, that is the only time that you acknowledge yourself as a surgeon. Otherwise, you're still in that learning phase. So there are many people who want to understand, sir, what is the incubation period? It depends on how talkative you are. You have to be talkative to become a good doctor. So don't show attitude in front of patient. You can show it your flamboyancy, attitude in front of everyone, but don't show it in front of the patients. You have to be friendly. What is the difference between a quack and us? We cannot go to their level and treat. But if you say their social IQ is very high, anything happens, they go to the patient's home. Even if they have a thermometer, they'll put a thermometer and check the BP from thermometer and say, okay, it is 130/90. And if someone asks her, how can you do this? How this thermometer is telling you, they will tell that this is a new technique and this and that, and patient will believe. So actually, this is the trust factor that they have generated, and same is the thing that you have to learn from them, that you have to make the patient your own patient, and this is the time when you are actually maturing yourself. The second thing is, when you start performing, when you want to shorten your incubation period, be more available. Availability is the biggest thing that will cut short. So if you are available round the clock, this incubation period of 6, 7 years might fall short to even 2, 3 years, because more you practice, more you handle the patients, and more you actually get knowledge. It's only a name game that you have to create.
Okay, so basically, communication skills, empathy, and all, having contacts, and all this can help us establish a name in the incubation period, which could help us in the future, isn't it, sir?
Yeah.
Okay, so one next question is like being a surgeon as a practicing surgeon, does it affect the career if you work in a big city versus small city or a town? Like, how is the scenario changing in different places?
Definitely, there are a lot of aspects that we have to look in. We don't have to just outweigh the importance of settling in a big town versus small town. There are a lot of aspects that are involved. Like, what do you want? What do you want is very, 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 very important. If you want the name and the fame, it is the tier 1 city where you will have to settle. I know it's very tough, but it will take some time. It will take some time. You have to acclimatize. You have to be patient for that. But yes, if you want a quick and sustainable growth in a very short time, then tier 2 and tier 3 cities, because I was telling this fact that patients will be there everywhere. Where the human life is existing, the patients will be there, and most of the patients will prefer to get operated in the local scenario only. So yes, very soon you get acknowledged as a surgeon. But as far as critical cases are concerned, as far as the big challenging cases are concerned, whenever you suppose there's let us think retrospective from a tier 2 or tier 3 cities patient's perspective. If you tell them that you have a suspected cholangio-CA or CA gallbladder, he will never get operated here. वो कहेंगे, go to Mumbai, go to Delhi, go to Kolkata, go to Hyderabad, go to Chennai. So there, the patient will have to access the tier 1 city. And that is the time when you treat them. Actually, a tier 2 surgeon might have also treated, but they don't have that confident quotient. So that confident quotient is missing there. So when you come for a tier 1 city, you meet and they say, no, yeah, there is a difference. A doctor or a doctor from Bangalore has that swag which a surgeon might not be having in a tier 2. But if you see on the other side of the coin, the competition here is more difficult. Setting up one's own hospital in a tier 1 city is next to impossible, because yes, it's a financial burden. And if you invest like I have, I might have invested is somewhere around 25 years. The time that I will take to revenge out this 25 CRs, if I would have invested this 25 CRs in share market or in the, you can say, different profiles, I would have made more money. So thinking you can say returns, you're not going to get any return in this tier 1 city. But yes, one return that you get, you grow, you grow. Like today, you called me surgeon, and I could acknowledge myself on the global, you can say, platform just because I'm settled in Delhi. Had I been settled in, like I belong from Kanpur, had I been settled in Kanpur, yes, I would have done a lot of cholecystectomies or hernias or hydrocele, but I have not got any onco surgery. I would have not got that name and acclaim. So that is where the difference is. What you want, money versus fame. Because in tier 1 city, take my words, your counterparts who are settled in tier 2, they'll very, very soon post a video or a photo on Facebook with a big mansion, having a lush green lawn with a good swimming pool and enjoying the beer around or a glass of whiskey around. But aap kya karoge? You must be, if you talk about tier 1 city, you'll be living in a society, in a flat. Maybe his mansion costed him 4 crores and your flat costed you a 4 BHK flat costed you 5 crores in that. But if you see the quality of life that guy is enjoying, the quality that you are enjoying, it's different. So even if you want to live in that lush green mansion in Delhi, it's not possible. The same is the case with other places also. So yes, there are two aspects of the point.
Okay, so it's first a student must find out, a person before taking should understand like what he wants, whether the name, fame, or the money aspect, and choose wisely, isn't it? Thank you, sir, for that. Our next doubt is, so is there a difference in working in a government setup or a corporate setup versus a personal setup? So which is like more profitable or in a, or
I will always like to answer this question, because there was a time when corporatization was at its peak. And that was a time when doctors were getting a very good salary. And that was a time, I think, I would say that was early 2000s, basically it's year 2000 to 2008, or maybe 10 also, when the corporates to pay a huge salary, huge salary. After that, what happens now, most of the corporates, they give a very minimum guarantee. And when you're talking about minimal guarantee, it's not, you can say, a very good amount. And then the corporate atmosphere is a lot more toxic in the sense, like you are a doctor and majority of the corporates are run by a handful of MBAs. So like if I'm talking to you, so it's just like, hi Saurabh, hi, how are you? MBA guys talking to me like this. So many a times it takes some time to acclimatize myself. Who is Saurabh? Okay, because we are acclimatized to that Dr. Saurabh tag. So hi Saurabh, hi, how are you? And everything is fine. And this month we have noted that the amount of patient load is falling very drastically. And as per as the, you can say, your payouts are concerned, it's not matching with the, you can say, inputs that you have put. Doctor, please try to manage this, else we'll have to take some pay cuts. And what is this? Was this the environment that we wanted around? No. Second problem in corporates is that you are responsible for everything. You know, right now I have 8 bodyguards. Now you must be astonished why I'm having 8 bodyguards. I'll tell you a scenario. I was doing a lap colorectal surgery, and you know that leaks are inevident. So it's the patient's body which will adapt to that scenario. So it was a young patient and a 45-year-old patient. Leak happened on day 4, and we did a second surgery. A stoma was created, and patient succumbed to her illness on day 25. So now it was a bill of 25 lakhs which was generated in the hospital, and you know there were 300 people who surrounded me in the hospital. Now tell me, these private hospitals boast of their security and everything. Yeah. So how did these 300 people manage? If they managed, what was the administration doing? Where was the police? I'm talking a scenario of a hospital in Dwarika, and they have actually cleaned their image by saying, I don't have any problem with you people. You talk to the doctor and settle your scores. Now, is this the day we are waiting for? Are we so much greedy that this is the scenario that we get slaughtered in front of the mob, or we get a part of mob lynching, and then hospital will say, okay, we tried to do our best and there was a case, doctor se case kharab ho gaya and this didn't go well, and now the patients gushed into the hospital and their attendants actually did this. So that was the time I decided myself, I will earn less, I'll spend less, but I'll live more. And in this 22nd or 20th century where we are living, वो एक कहते हैं ना कि भाई इंडिया में बाहुबली का कल्चर आ गया है, चाहे पॉलिटिक्स हो चाहे कहीं भी हो, तो पॉलिटिक्स तो यहाँ पर भी वही कल्चर है. So you have to have that might in order to fight with the society. So that is what. It's not like my bodyguards are thrashing everyone and this and that. But we, since I'm running a hospital, we know that importance of life. But unfortunately, if you're not able to save the life of a single patient or someone, they have that momentary, you can say, hit of the moment, they might, you can say, be enraged and they try to take revenge. And that is the time that we need them the maximum. So corporate में ये चीज होती है कि भाई, if you are not able to perform, you are out. Seniority, juniority, nothing matters in corporate. The only thing matters is how well you are able to give revenue to them. If you are able, then it's fine. Otherwise, what happens? Majority of the very big surgeons, they join Apollo and then they go to Max and then they go to Fortis and then they go to a different group. So this keeps on happening, reshuffling. But if you see, I have seen my Professor Abhimanyu Basu, sir started his journey from one medical college and then he came to SSKM. And then again, he went for some time to a medical college. And then right now, he's the head of department of IPGMR and SSKM. I feel proud that so many generations have passed under him. The second thing is, if you see the financial levels, nowadays, majority of the government sectors are also paying you a decent sum. They're paying you a decent lump sum. And if you think like, there are a lot of people who think that I will do a MCH gastro and I'll start earning 20 lakhs. Take my words. The day you start with MCH gastro, you come to my hospital or you go to any corporate hospital, they're not going to pay you more than 2.5 lakhs. इससे ज़्यादा नहीं देते. आप कहोगे कि ठीक है, to start with they're paying you 2.5 lakhs. Maybe after 5 years I'll be getting 15 lakhs. This is again wrong. After 5 years they will say, sir, 2.5 lakhs plus 10% or 20% of whatever work, or maybe 30% if you're a very good big short surgeon, or whatever business you are doing. So that is how they've started to play smart. Then your personal growth, yes, is there depending upon what kind of, you can say, field you have been into. So when you talk about a government college, since it's an institution, you have a team, you get a decent sum of money, but your choice is very important. Like what kind of profile you want to create. You want to create a glam sham profile, definitely you will have to go to a private hospital. But remember, in private hospital, you are responsible for your everything. You're responsible for your success also, you're responsible for your flamboyancy also, and you are responsible for your mistakes also. No one is there to defend. In a government hospital, what kind of mindset you need to go with? First of all, we have to have that, you can say, thought process that what we have got from the society and what we are returning. So if you want to return something, then yes, join a government institution where you will be handling a lot of your juniors, where you will be teaching them. And then second is, if you want to operate on big cases, then you will need to go to an institutional centers like big medical colleges. Why? Because none of the private corporate hospitals, they're dealing with critical cases, because they know that first of all, the cost of a critical case might go to anything. I've seen bills going to 40 lakhs, 50 lakhs, and that is why they know that patient nahi de payega. Ye patient nahi de payega, and that is why they say go to AIMS, go to PGI, go to Chipmer, go to IPGI. So basically, you're not having empathy for that patient. You wanted to do something, but your institution is not allowing you. So you cannot blame the institution. You should be blaming yourself, because you went to that system. It was your choice. So yes, there is, I would always say that because I'm running a private hospital, I know the inside out of everything. As a doctor also, I've worked with all the corporates of Delhi, and now I'm running as a director. So I will always look into my pocket as how much money can we generate from the patients, but yes, ethically. But if you talk about big corporate hospitals, वो ethics और वो उनके बीच का जो explanation है, that is a bit ill defined. I'm not saying that they're not following a holistic approach of treatment, but yes, they are having a big team where the payroll might go up to maybe 6 crores also, 5 crores also. So definitely need to take out. But when you talk about a government setup, you're free. If anything happens, you call your juniors and say, "Bhai, aajo matter ho gaya." And then your juniors, residents, everyone comes for a fight, and then you can settle out the score there also. The second thing is the learning curve that you get in private is not there. Why? Because they are not going to allow you to learn. They want the filtered best products. But if you are a young surgeon and if you join a government hospital, because professors are not going to do a lot of cases, it is the APs, it is the associates who are actually going to get a lot of workload, and that is a time when you practice variety of cases and then you start learning that. So that learning curve starts with your residency and continues your journey of life and maybe any time. So private may you should have, you can say, guts to practice properly in the scenario that we have right now. So the scenario was quite good in the private hospitals in the early 2000s, but what I think personally, it is not that very good, because nowadays even government hospitals are doing very good, and they're giving a decent payout, they're giving a decent salary. Along with that, you get a lot of exposure, lot of variety of cases, वो शायद आपको private hospitals में नहीं मिलेंगे. But still, if you don't want to work in that government hospital, you can join private, but job surety is there in private, your gratuity is there, maybe pension is not there, but gratuity is there. You have that freedom that yes, if you're not there for 4 or 5 days, you will arrange for a replacement and the patient will not be complaining. And here, if you have operated on patient, it's like whenever I go out for a vacation, it feels that whole of the world will get ill right now during these 3-4 days and keep on getting calls one after another, doctor kab aa rahe ho? And many times I start feeling guilty कि यार मैं गया ही क्यों. जैसे you land up to a place, you start getting missed calls and sir, this is the problem, हम आपके ऑफिस में बैठे हुए हैं, आप वो पेशेंट वो कह रहे हैं डॉक्टर साहब है नहीं, डॉक्टर साहब आज ही ऑपरेट कराना है, this and that. So ये सारी चीजें, the responsibility is less in a government hospital, and yes, the job surety is more, protective instinct is more. So during the initial years when you're learning, basically I would say the initial 3-4 years you try to spend in a government hospital where you will acquire something and learn, because in MS particularly you learn only the attitude and the skill, but polishing that skill, yes, either you enter into MCH, even if you go for MCH also, after 3 years you pass out from that, again that learning curve and polishing curve is there. So it is your own choice, but I would say government and private both are good options. But if you see the current scenario of the private hospitals, if you get a government hospital with a good salary, I would always go for that.
Okay, sir. That was really nice of you to give us a complete light on all the separate sectors, government versus corporate and personal. So coming next to the question of super specialization and fellowship add-ons. So what are the available options, and is a post specialization a must now in the field of general surgery?
I would like to say that if you are settling in a tier 1 city, yes, there are a lot of specializations you need to do. Again, this is a corporate bubble which has been created by corporates. Like one thing that a patient acknowledges is how well you treat the patient. You may be a MCS surgical onco or MCS surgical gastro, and if you don't have a good track record of clean cut cases, you are of no use. If you talk about a good, if you have done your MS from a good hospital, where actually you have got a good hands-on training, you can do any GI case. There is no problem. Like I routinely do all GI cases. There is no problem. So I routinely do all GI cases. There is no problem because I can explain them. The next thing is that yes, these add-on are must, because now it's a time of pomp and show. The longer the list of the degrees that you attach, the more you can say accessible you are to the patients, and they are willing to get operated from you. So yes, these fellowships and tags are very important. Like because like when you talk about laparoscopic surgeries, many of the students ask me, sir, why you didn't go for MCH and this and that. I said, I always wanted to become a laparoscopic surgeon, and there is nothing known as MCH. There is FNB, there are fellowships and there are diplomas that we have in minimal access surgery. And right now, that is what is actually the maximum available thing. So now when I am a laparoscopic surgeon, I'm doing all laparoscopic cases, I'm doing hysterectomy. Now tell me which general surgeon will do a hysterectomy. So either a gynecologist will do, she doesn't know well how to do, and if she knows, she doesn't know the laparoscopy. So the plight of the patient is that patient was a scarless surgery, and that is why a lot of laparoscopic surgeons, they do all the, any organ that is visible inside the stomach, they're ready to remove it. Any visible inside the thorax, they're ready to do it. So basically laparoscopic surgery covers a lot of things, but yes, you need to acknowledge it with your hard work, because it's a skill which takes time. Now suppose you want to settle in a tier 2 city, and you want to, you have done an MC, you have done MCH, or you want to pursue for MCH. So now the branches for you, if you take MCH gastro and settle in a tier 3 city, you will not have patient. When you do MCH gastro, you should be settling yourself in a tier 1 city only, where actually people acknowledge the difference between a quack and a surgeon and a, you can say, a super specialist also. यहाँ पर डिफरेंस आता है. अब छोटे शहर में आप न्यूरो सर्जरी लेके बैठ जाओगे, आपके पास क्या आएगा? There will be nothing. You might be doing burr holes, or you might be earning a good money. That is different. That is one prospect. But whatever you have learned, do you think that you will get any new brain tumors to patient to get operated from you in a small city? They'll always prefer to go to a big city like Kolkata, Delhi, Mumbai, Chennai. So ये एक mindset बहुत जरूरी होता है. ऐसा कंपलसरी नहीं है. दिस इज नॉट कंपलसरी एट ऑल कि आपको सर्जरी के बाद एमसीएच करना ही करना है. ऐसा कहीं भी नहीं होता. द ओनली थिंग दैट यू नीड इज यू हैव टू बी प्रेजेंटेबल. देयर आर लॉट ऑफ फेलोशिप्स अवेलेबल. यू कैन डू दोस फेलोशिप्स एंड स्टार्ट योर करियर. द फर्स्ट थिंग इज योर ट्रैक रिकॉर्ड शुड बी क्लियर. लेट मी टेल यू, you do any degree, and if you're not able to justify your skills, you are lost, and you get only one attempt. Only one attempt. And that is why in surgery it is said that learn what to cut, when to cut, and what not to cut. And this is the most important 3 pillars. If you learn them, आप कुछ भी कर सकते हो. Yes, अगर आप corporates में जाओगे ना, तो corporates ने एक bifurcation कर रखा है, और उस bifurcation का सबसे बड़ा reason है the finance. Actually, if you get admitted in under a general surgery, वो इंश्योरेंस वाले ना उतना पैसा नहीं देंगे उसी केस का. बट सेम पेशेंट्स, सेम सर्जरी बीइंग डन अंडर अ गैस्ट्रो सर्जरी डिपार्टमेंट, भले आप उसी जनरल सर्जन से करा दो. सो व्हाट हैपेंस, दे कैन क्लेम फॉर अ हायर अमाउंट. सो एक्चुअली वी आर जस्ट अ स्मॉल कल्प्रिट इन दिस इंडस्ट्री. वी कीप ऑन थिंकिंग ये वो. यू नो व्हाट इज द मेन रीजन बिहाइंड द वॉर्स? Is it like I don't like your face or you don't like my face and we are going to fight? Actually, war is going to change or shake the stocks, the exchange rates, the economics. And you know, these oligarchs, they are the one who are actually ruling the world. We have 2-in-1 TPN, we have 3-in-1 TPN. Why is not India using 2-in-1? And why is America using not using 3-in-1? The simple reason is that in America, everything is controlled by the finance. Everything is under insurance. A laparoscopic cholecystectomy, which might go, if you talk about a higher range, might go to 1 lakh in Delhi, is charged at a rate of 7 or 8 lakhs in, you can say, US, because everything is under the insurance, so they don't have to pay. But now let us take the retrospective or the other side of the coin. If we use a 2-in-1 TPN versus a 3-in-1 TPN, 3-in-1 TPN is having lipids, and lipids are known to prolong the hospital stay. Basically, they're going to increase the hospital stay. So on an average, if hospital stays prolonged, single patient, and there are 50,000 users, so that is 5 into 50,000, that is 2.5 lakh TPN days financial load on insurance companies. So they persuaded everyone to change the strategy, and that is why वहाँ पर 2-in-1 है. हमारे यहाँ 3-in-1 है, because हम कहते नहीं है भाई हमें lipids दो, because between ADE के कहाँ से absorb होगा. So we justify ourselves in terms of technicality. But actually, every second, their stocks, their rates. Today, I was reading a paper, and Mr. Adani, we are proud that he has gone up to rank 4 So he's the fourth most richest one, and everything he has actually acquired is in 2021. And you know, in 2021, his wealth was growing. Take my words, read Times of India, his wealth was growing at a rate of 6,000 crores per week. 6,000 crore per week. हम अपनी फैटर्निटी की भी इनकम जोड़ लें तो शायद साल में इतनी ना निकले जितना उन्होंने हर हफ्ते कमाया है. So this is actually the handful of rich people which is controlling everything, and that is why the corporate culture, the MCH culture, and more tunnel and pinhole vision, so that we can precise and separate these things, and we can actually get the benefits. So if you go back to 30 years when corporates were not there, the MCS culture was not there. At that time, even general surgeons were doing thoracic surgeries. They were doing a lot of surgeries. Yeah, there are certain departments which needs a segregation, like CTVS, cardiothoracic, because their work is more precise, more experienced. So earlier people used to work in those departments and get acknowledged. So वो धीरे धीरे, मैं ये नहीं कह रहा हूँ कि MCH is not important. MCH is very, very, very important right now because the trend is there, everything is there. But blindly following the corporate culture with respect to this MCH, I always condemn that thing. So yes, you want to become a specialist, that is why you should be going for that specific branch. But ये corporates ने इसका बहुत segregation कर रखा है. अगर आप general surgeon, as a general surgeon, if you join, you can say MCH, corporate hospital, तो बहुत discrimination होता है. आधे patient आपके पास आते हैं, आधे patient gastro surgery के पास आते हैं. एक पेशेंट कहता है कि मुझे गॉल ब्लैडर की सर्जरी गैस्ट्रो सर्जन से करानी है. अब जिसने गॉल ब्लैडर किया ही नहीं है बहुत सालों से, उसको आते हैं ओपन सर्जरीज. वो कैसे लैब जस्टिफाई कर पाएगा अगर थोड़ी सी भी टफ हो गई? सो वहां बहुत सारी चीज होती है. जनरल सर्जन आज के डेट में लैब कर रहे हैं, लैप्रोस्कोपी करा रही है. और जनरल और जो गैस्ट्रो सर्जन होते हैं उसमें से सिर्फ 10% या 15% या 30% एट मैक्स आर कॉम्पिटेंट इनफ टू डू अ गुड लैप्रोस्कोपिक विपल्स और गुड लैप्रोस्कोपिक कोलोरेक्टल. तो यहाँ पर प्रॉब्लम्स खड़ी होती है. सो देयर इज अ ग्रे जोन, देयर इज अ वाटरशेड जोन where yes, the skills need to be justified with the, you can say, learning process.
Sir, all this information is like really new to us, and you know we have never thought about the corporate sort of mind of people. Right now, we're throwing us a lot of information, all that, and thank you, sir, for that. So coming to next question, this is a doubt which everybody has because UG life, coming to general surgery, all that we are mostly exposed is to surgeries of appendix and hernia and maximum varicose veins and breast lump removal. So during residency, are we limited to these cases only, or do we have exposure to other cases too?
No, it's not like that. During residency, you get a lot of good cases. You get colorectal, you get hepatocellular cancers, basically maybe CAGB. It's all depends upon the segregations. Like if you get a patient, suppose in your OPD, like I'll tell you about IPGMia. So if you used to get a patient of cholangio-CA, or if you get a question, I think someone wants to ask a question also. Okay, we can allow Vivek also to ask his question. So यहाँ पर क्या होता है कि हम उस patient को अपने department में रखते हैं कि नहीं, and that all depends upon the unit that you are. So whenever I used to get a patient of suspected pancreatic SOL, we always used to prepare that patient for Whipples. Now, if you see Whipples, gastrosurgery people are also doing, and we are also doing. So, ऐसा कहीं भी नहीं है. It depends upon what unit you are. If your professor is not willing to do a Whipples because he is not trained enough to do Whipples, वो कहेगा इसको gastrosurgery भेज दो. हम तो कोई patient नहीं भेजते थे सिर्फ liver transplant छोड़ के. अगर liver transplant का patient है तभी हम भेजते थे, कहते कि भाई चले जाओ. अब आज के डेट में अगर मुझे लिवर ट्रांसप्लांट करना है, आपको क्या लगता है कि एमसीएच करने के बाद आप लिवर ट्रांसप्लांट कर सकते हैं? नहीं. अगर मुझे करना है तो मैं 1 साल की फेलोशिप करूंगा एंड आई विल स्टार्ट डूइंग अ लिवर ट्रांसप्लांट. सो अगेन देयर आर लॉट ऑफ ग्रे एरियाज. इवन आफ्टर टेकिंग एमसीएच आल्सो एज अ रूट, you don't get complete, so you need to decide what you want to be. Surgical load, as far as variety of cases is concerned, this depends upon center to center. Like you are going to PGI Chandigarh, वहां पर गैस्ट्रो सर्जरी और या डिफरेंट यूरोलॉजी या फिर डिफरेंट जो ब्रांचेस हैं, उनके पेशेंट्स पहले ही you can say they get siphoned into their respective branches, and there actually you get a very poor load of in the department of general surgery. So common cases ही मिलते रहते हैं. ना उन्हें कोलोरेक्टल बहुत अच्छा देखने को मिलता है. So this depends a lot on the institution from where you are doing the things.
Thank you, sir. So again, like there's a space where there's a blending of two fields. So like for example, cerebrovascular surgeon and neurosurgery. Is there like in same way like in cases of general surgery, like coming to gastro surgeries, interventional surgeries where endoscopic interventional surgeries are coming right now. So is there is it like a threat for the general surgeons, because not exactly like a threat, but are their chances getting less when these super specialties are rising? Is what I'm asking. Like,
Try to understand. You need to evolve yourself with the time. As the things are coming, you will have to learn. Like I'll talk about interventions. So 2 days before, I got a patient planned for a varicose vein patient planned for EVER, endovascular aneurysmal. That EVLA, that endovascular laser ablation. So we are doing that laser ablation. So we have to keep ourselves updated with the technology. So as far as endoscopies are concerned, as a surgeon, you can do an endoscopic workshop and endoscopic fellowship, and you can start doing endoscopy. You can do ERCP. Majority of the good endoscopic doctors who are doing the greatest of the ERCPs are all surgeons. आपको क्या लगता है भाई, हम जब एंडोस्कोपी करते हैं, हमने मान लीजिए एमएस किया, अब हमें लगता है कि we have a notion that DM Gastro will do endoscopy. So for the first time, they are converting their physician-based branch to an intervention branch. उनको सबसे ज्यादा डर लगता है कि if the esophagus gets perforated, what happens? Then going down, if the duodenum gets perforated, what will happen? हमें कुछ नहीं डर लगता है. हमें पता है कि अगर esophagus फटा तो उसको कैसे रिपेयर करना है. Duodenum फटा, कोई बात नहीं है, perforations तो होते ही हैं. So that is the backup that we have, and we can do anything. Like if you say that I will stay only MS surgeon, this is not going to work. You have to learn. You have to learn. If you say ki today I'll just remain as an MS surgeon and after passing out from medical college, I'll start making a lot of things, it's not possible. The only thing that you need is you go to a very remote place from where only you can earn. So definitely you need to evolve yourself with the updates. You need to, there are a lot of fellowships which are there, so you can do those fellowships instead of wasting time with MCH if you don't want in case. So you can always go for. And आपको कोई मना नहीं करेगा. अगर आपने 1 साल की यूरोलॉजी की फेलोशिप कर ली है और अगर आप यूरेट्रिक स्टोन्स कर रहे हो, यू कैन जस्टिफाई योर स्किल्स. यू कैन जस्टिफाई. अब आप 1 साल की यूरोलॉजी फेलोशिप करने के बाद अगर आप कहते हो कि नहीं मैं रीनल ट्रांसप्लांट करूंगा, दिस इज नॉट जस्टिफाइबल बिकॉज नॉट ट्रेन्ड इनफ टू डू दैट. So basically, MCI or NMC, whatever you say, or any medical council, they acknowledge you on the terms of whether you are experienced enough to do that case or no. If you're not, then वो medical legal negligence बनती है. Otherwise, yes, anything can happen with the trained hands also.
Thank you, sir. There's a question from someone who's watching right now.
Debraj has asked, sir, similarly, can a general surgeon do a percutaneous interventions? But say generally, it's not a domain which the cardiothoracic surgeons want to enter, basically. If you talk about PTCIs, etc., which there may be some people who might want to do, but that's not a domain actually where, so there are some cases like angioplasty, yes, a surgeon can do anytime he wants if he is a cardiothoracic surgeon, but a general surgeon cannot do this because he is not trained enough to do that. He has to work or he has to take a fellowship and then only he might be allowed. But यहाँ पर एक domain ऐसा आता है कि जहाँ पर कोई course available नहीं है, that general surgeons will be taught about the intervention radiology or intervention procedures. But yes, if you work in the department and you're trained enough, you can do it. Hardly takes 6 months. But more than that is the proficiency learning phase, how well you learn that thing. So कुछ gray areas हैं जहाँ पर आप नहीं जा सकते, but as far as endoscopies are concerned, as far as basic procedures are concerned, you can always learn from the different field. So when they can do the intervention, the physicians can do the interventions, why can't you do their job? That is what is clear.
So next question is about the monetary profits that we can make as a surgeon. So like, what is on average, how much can a person make, and how much is a growth scale?
It starts all from the day, from the time you enter into the market. So don't think that you have acquired a degree and then you are entering. It is the market phase which is important. So generally, you usually start as a resident with 90 lakhs or 90,000 to 1 lakh rupees per month, or maybe 1.5 if you are working in a corporate atmosphere. But yes, the growth from here is depending upon how you mature yourself. So age is just a number. It is your clientele base, how well you develop your clientele. That is what going to be. Like I started my phase with a very meager amount, but now I'm confidently earning good amount because there are two aspects. Now I have my own hospital, so I don't have to share anything with anyone except the anesthesia fees, except for the some small investment in drugs and medicine. But if you see counter perspective, I had to generate enormous wealth to create that institution where I could actually work peacefully. So ये सबके साथ नहीं possible होता है. But yes, it takes 4 to 5 years or maybe 6 years to generate a decent amount of living. Otherwise, that phase is really very, you can say, tough. One advantage that you have after doing MCH, you get specialized in, or you just get a super specialty. So if you go to any institution, you get a lump sum pay around 3 or 2.5 lakhs, or in some peripheral cities, they even pay you 4 lakhs or 5 lakhs also. So if you do, like, if you talk about DM Gastro, let us take on a medicine part. To DM Gastro, there is a lot of demand of angioplasty, etc. So even in a peripheral city, you get a good salary. But just parallel to that, if you're a CTVS surgeon and you get settled in a tier 3 city, no one will acknowledge you. Here, now in a city like Delhi, if you go to a corporate hospital who's having a good cardiothoracic load, they will give you a decent amount of 5 lakhs, 6 lakhs, 7 lakhs also, depending upon their patient load. But here, now when you talk about the gastro, DM Gastro, they will always say, sir, 2 lakhs is the guarantee, and then the level of work and the percentage sharing. So it depends upon all your work. You can go 10 lakhs also, 12 lakhs also, or you can stay at 4 lakhs also. So it all depends upon your work. So the corporate, the salaries are a bit different and variable. There, the perks are more. And as far as a basic life is concerned, if you join a government hospital, yes, it's like a tortoise race, but it's a constant salary that continues. So you can do a financial planning with a government, you can say, job, but doing a financial planning with a corporate job is very difficult, because one fine day you know that you have a package of 2 crores a year, and then after 6 months, all of a sudden there is so much big terms and conditions they have there in that contract. They can anytime terminate you, giving you a 15-day notice, and then now you're thinking how to pay the EMIs of the home, how to pay the EMIs of the car. So ये एक बहुत बड़ा challenge होता है. So my request to all the surgeon is that in the initial phase, try to accumulate the amount, make your own small center, even if it is a 5-bed center, 6-bed center, you can start doing your own cases there. So that is the big advantage that you get. And as far as earning in tier 2 and tier 3 cities, it's always 2x the amount that you earn in a tier 1 city. Take my words, 2x the amount that you earn at the same age level. So ये होता है, बहुत जल्दी आप सेटल हो जाते हो tier 2 cities में, और नाम भी जल्दी बनता है. यहाँ पर when the seniors will leave the podium, then only you will get a chance to step into that podium and stand and say, okay, now I am the Don. So by the time you start earning, or you develop that, you can say, financial background, that you can buy a Mercedes S-Class, or you can say a Porsche, you are actually losing the interest in that vehicle, because now the age is gone. So ये जो एक फैक्टर है ना, ये बहुत बड़ा फैक्टर है. आपके जब तमन्ना थी, ख्वाहिश थी, तब आपको मिल नहीं पाया, because there's a cutthroat competition. And then at the age of 50, you are buying a Mercedes S-Class, and then you are trying to, मोहल्ले में भी घुमाओगे या एरिया में भी घूमोगे तो लोग कहेंगे यार अंकल जी शॉक कर रहे हैं. वो जो चाइल्डहुड फैंटेसीज थी ना कि यार हम वो कबीर सिंह की तरह ये करेंगे वो करेंगे, वो सब यहाँ कुछ होता नहीं है. दिस इज नॉट द रियलिटी. Yeah, I had a dream of riding Royal Enfield, and you know, I always wanted to buy a Royal Enfield, but financial crunch was there. I couldn't buy, and that was always, and that's still my dream. Right, whenever I see a guy using that Royal Enfield, लगता है कि कर ले. Today I can buy any vehicle, but now वो time है, and now the scenario is not there. So yes, you have to decide what you want in your life. Settling in a tier 1 city is not a small decision. It takes a lot of courage to settle here, because first of all, you for the initial 4-5 years will be screwed badly from the industry, and then It is you, your skills, how well you can control them. Because once you are in a controlling position, the corporates will run behind you, not in front of you. You say, I want this, they will be giving you this. You say, I want this. उनको लगता है बस ये ना जाए, ये महाराज ना जाए. अगर ये गया तो सब गया. So that is what. That is why the time is important. You have to give some time. तो अगर क्विक मनी जल्दी सेटल होना है तो टीयर 2 टीयर 3 सिटी से अच्छा कोई ऑप्शन नहीं होता है. और अगर लगता है कि नहीं यार मुझे एक ब्रांड बनानी है, मुझे बहुत बड़ी ब्रांड बननी है जिससे ग्लोबल लेवल पे एक्नॉलेज करे, सो यस इट इज टियर 1 इज द चॉइस.
Thank you, sir. Thank you, sir, for like telling us a lot about that. So coming to the next topic is about robotic surgery. And being a laparoscopic surgeon, you will be knowing how it has helped you in your growth. Same way, robotics is also coming into the domain right now. So will it impact after a few years, or what is your prediction regarding that? Is it like a boon for the surgeons, or
let me tell you, robotics came into this industry in 2008, and we were expecting a lot of, you can say, lot of buzz was there about robotics. But since the insurance companies are still not covering everything, and the second part is the cost of running a robot and a center equipped with robotics is very high. Like today, if you talk about the CMR robot, and if you talk about the Da Vinci, one very important thing that we have to understand is that the cost of logistics, it's not the one-time cost, because you have giants. Even I can afford to take on a loan a robot and set up in my hospital, because I am die-hard ardent fan of robotic surgery. But the problem is that when I do a robotics, the cost of logistics is going to kill me. The patient is not going to pay for that, and then the insurance companies are not going to. So Indian mindset is like we still have to wait for some long. And then the second problem is with the robotics is most of the surgeries that are done with a robot are more comfortably done with the laparoscopic surgeries, except for the urological procedures where the robotic surgeries have proven that yes, it's going to be different. Like if you're doing a prostate, laparoscopic prostate versus a robotic prostate, you'll feel like enjoying doing a robotic prostate, robot-assisted laparoscopic prostatectomy. But the collateral is the cost, the maintenance. The AMC of a robot is 75 lakhs. अब 75 लाख की तो आप सेल नहीं कर पाओगे, हो सकता है इनिशियल 1-2 साल में. So that is a big burden. आपको बहुत सारी प्रॉब्लम्स होती हैं, बहुत सारी चीजें होती हैं जो आपको सेटल करनी होती हैं, and it becomes very difficult to maintain a robot. That is why many of the centers, they get a robot and then they're not doing that. In a robot we have instruments which have a fixed use. If 10 uses are there, so every time you plug in that instrument, the robot, they are hyper smart, they count it as one. So suppose in a surgery we've used 3 robots, 3 robotic instruments. So that cost, suppose if now the standard cost is somewhere around 2 lakhs plus GST, a single inch robotic grasper. अगर आप देखो तो एक इंस्ट्रूमेंट का एक यूज लगभग आपका 22,000-25,000 का पड़ता है. तो एक सर्जरी में आपने कम से कम 65 to 75,000 की लॉजिस्टिक यूज कर दी, जो कि एक्सप्लेनेबल नहीं होता. So still waiting for the cheaper alternatives. Like one of my friend who is dealing in this medical, lot of equipments, he's regular to China. So I am also working with them in setting up a cheaper variant of robot, because nowadays the robotics, the patent has ended for Da Vinci, and many new players might come in that 5 to 7 years, where we might bring the cost of this robot from 14 crores to 2 crores or maybe 2.5 crores. Yes, we are setting up a lab in Laos, in Vietnam. So we are actually planning for something from Chinese companies. Don't think that Chinese are bad. Everything you buy is from China only. Everything which is international brand you name is from China. So I don't say that Chinese are bad. They're excellent people as far as hard work is concerned and technology is concerned. Due to political propagandas, we say कि भाई ठीक है, we have to abolish them. But अगर China को abolish कर दोगे, Chinese products को abolish कर दोगे, survival नहीं है. Right from the perfumes that from the cologne, right from the iPhone that you use, the chips, the semiconductors, everything is getting imported from China. So yes, we are waiting for cheaper alternatives where we can use the conventional instruments along with the conventional robot. That will be the time when robot will be there in every center. पर जब तक ये रोबोट का एक जो ये ऑरा नहीं खत्म होता कि भाई इसकी कॉस्ट ऑफ रनिंग पेशेंट्स के लिए बहुत इंपॉर्टेंट है, इंस्टीट्यूशंस के लिए, भाई विल नॉट गेट दैट मेनी केसेस, विल नॉट बी एबल टू मैनेज दोस. So the big institutions, the corporate ones, are still able to manage because yes, they are getting the caseload. Otherwise, the robotics has no access to the smaller centers, and this is actually the microeconomy is more important in every sphere. So macro is the corporate giants, the micro is the mid-segment hospitals like us. So जिस दिन robotics यहाँ भी आ गई, उस दिन हम कहेंगे कि yes, robotic is taking a bloom. Let me give you an example. In US, robotic surgery has 70% you can say penetration, but in UK 10% or less. Why? Because UK is run on national medical schemes, because there are no privatization of health. You have the NMC, or you can say you have the government who is making the schemes. So government will always get something which is good, which is cheap, affordable, and reusable. And that is why the CMRs, or the you can say the Vincis in UK, they're far less than the number of robots which are there in you can say US. तो ये एक जो ट्रांजिशन है, इसमें बहुत सारा टाइम लगेगा. कंट्रीज को इंटरवीन करना चाहिए, गवर्नमेंट को इंटरवीन करना चाहिए टू सेट अप सब्सिडी फॉर देम. आपको 200% वो भी चाहिए, 204% इंपोर्ट ड्यूटी भी चाहिए. फिर जितने इंस्ट्रूमेंट्स आते हैं उस पर भी आपको इंपोर्ट ड्यूटी चाहिए. तो आपने कॉस्ट तो एक तरफ बहुत बढ़ा दी, और दूसरी तरफ कहते हो यार देश का ना वो नहीं अच्छा है, इसीलिए हमारे नेता जब भी बीमार पड़ते हैं सबसे पहले सिंगापुर जाते हैं. वो हमारे कंट्री में क्यों नहीं ट्रीट कराते? वो क्यों लंदन जाते हैं ट्रीटमेंट, यूएस जाते हैं ट्रीटमेंट कराने? आप अगर देश को देखें तो देश में टैलेंट है. ये सिंगापुर में भी जो बड़े डॉक्टर्स हैं वो इंडियन है. ये यूके में भी, ये यूएस में भी जितने बड़े डॉक्टर्स हैं सब इंडियन है. यहाँ पर वो हमारी कहते हैं ना कि भाई किसी अपने ने कह दिया कि तुम में हुनर नहीं है, है ना, फिर किसी दूसरे से कहलवा दिया कि होनहार हो तुम. इतनी बेकदरी से दिल तोड़ा मेरा कि आज मेरी कामयाबी के जिम्मेदार हो तुम. सो ये जो चीजें हैं ना, पहले हमारे कंट्री में वो पॉलिसीज देखते नहीं, और उसके बाद वो फिर वो कहते हैं कि भाई चलो वो अच्छा है. तो देयर शुड बी गवर्नमेंट इंटरवेंशन इन दिस, अदरवाइज वी नॉट गोइंग टू, हम इम्प्रूव नहीं कर पाएंगे. और थोड़ा सा कोलैटरल्स है, मेडिकल साइंसेज आ गई हैं हमारे पास, लाइक होम्योपैथी इज देयर, और immunopathy is there, mobopathy is there, and cowpathy is there. So मैं नहीं कहता कि भाई cow's urine is bad for health. There may be something. कुछ लोग उससे गोल्ड भी एक्सट्रैक्ट करते हैं. There are a lot of things like cow urine can treat stage 4 cancer, or there are people who say yoga can treat pancreatic cancer. तो इस तरीके की जब तक बातें इंडियन कंट्री में चलेंगी तब तक कैसे इंफ्रास्ट्रक्चर हम मॉब को डिस्काइज करें. मैं कहता हूँ आप योगा करोगे, दैट्स अ प्रिवेंशन इन पीएसएम. सो आपको फिट रखेगा, आपकी बॉडी को एजाइल रखेगा. और पैनक्रियाटिक कैंसर कैसे योगा ठीक कर सकता है? अगर मैं बोलूंगा तो मुझे लोग देशद्रोह कहेंगे, ये देशद्रोही है. पर मैं उनसे यही सवाल करना चाहता हूँ कि भाई हम अपने लेवल पे लोगों को राइट एजुकेशन राइट टाइम पे देना. अब एक पैनक्रियाटिक कैंसर हो गया, लाइक टुडे ओनली आई गॉट अ पेशेंट with a renal stone of 4 centimeter by 3 centimeter. Patient said what to do. I said it's a very big stone. ये तो nephrectomy करनी पड़ेगी. And do you know that patient told me that he for 8 years he has been on homeopathic medicine to dissolve the stone. Now a DTPA scan was done. The functional status of the patient's kidney was 5%. अब ये जो 5% की इसकी किडनी की वजह से इसको नेफ्रेक्टमी करानी पड़ेगी, इसके पीछे रिस्पॉन्सिबल कौन है? मैं नहीं. सो हमारा जो इंडियन मेडिकल सिस्टम है ना, वो बहुत ही अलग होता चला जा रहा है. वो ब्रिज कोर्स भी लगा रहे हैं, वो ब्रिज कोर्स भी लेके आ रहे हैं, ये कोर्स भी लेके आ रहे हैं. तो व्हाट आर वी ट्राइंग टू जनरेट? व्हाट इज द एंड प्रोडक्ट? ऑन वन साइड वी आर टॉकिंग अबाउट रोबोटिक्स. हम चाहते हैं कि भाई हमारा डॉक्टर ऐसा हो कि भाई बस आग लगा दे माहौल में, और अदर दूसरी साइड पे हमारे साथ आप उनको लेके आ रहे हो जिनका कोई टैलेंट नहीं है. सो अंटिल अनलेस वी डोंट डू दिस बाइफर्केशन, ये तो वही बात है ना, हम रोटी कपड़े मकान पे लगे हुए हैं और हम बात करते कि नहीं हम एक ग्रासलैंड बनाएंगे, वहां पर बड़ा लेविश स्विमिंग पूल बनाएंगे, वेव पूल भी बनाएंगे, माइलैंड खरीदेंगे. सो हमें अपने बेसिक इंफ्रास्ट्रक्चर को सबसे पहले ठीक करना पड़ेगा, माइंडसेट को ठीक करना पड़ेगा. आज की डेट में इफ यू थिंक पीपल हैव मोर हेट्रेड टुवर्ड्स डॉक्टर देन द लव. अगर एक डॉक्टर, एक देखो डॉक्टर भी एक इंसान होता है, उसने एक महंगा फोन लिया तो देखा इतना लूटते हैं, दैट इज व्हाई ही हैज बॉट दिस फोन. So this kind of mindset is wrong. If you go to US, if you go to UK, I know the number of litigations are more against doctor in those countries. Why litigations? Because people are educated, they're not happy दे विल टेक अ लीगल कोर्स. हमारे यहाँ क्या करते हैं भाई, वहीं पर सेटल कर लेते हैं. पीपल आर नॉट एडुकेटेड इनफ टू हैव द टेक्नोलॉजी. सो ये ग्रोथ टेक्नोलॉजी की भी तभी होगी जब लोगों का एजुकेशन लेवल बढ़ेगा. अदरवाइज ये ऐसे ही चलता रहेगा. We will keep on blaming one another for these things, and nothing will improve over the time. So yes, a time of robotics will also come, definitely, before it gets expired in the international scenario. हमारे इंडिया में फिर अभी भी टाइम है. जो रोबोटिक्स के क्लाइंट हैं वो रोबोटिक्स कराते हैं, बाहर जाके कराते हैं या फिर हाई एंड हॉस्पिटल्स में जाके कराते हैं. तो बहुत, जब तक कोई चीज एनमास नहीं जाएगी ना, 22 करोड़ लोगों में से अगर 10% भी एक्सेस कर पाए, तब उसे हम कहेंगे कि yes, that's a technologically proven product. If only 0.1 to 0.001% is using, that product is not valid.
Sir, I think there is a question in the chat box.
Yeah, I'll take that question also. Vivek Dubey. Sir, what are the do's and the don'ts in the general surgery resident must keep in mind during the first year and second year? So Vivek, sorry for being late, answering your question. I've already told, don't skip from the duties. Try to be involved in as many as cases involved. Scrub in all the big cases, try to be part of majority of the workshops that are being held, because that is the time when you get an international, you can say, acknowledgement with the faculties who are traveling to your center and they're operating on the cases, and learn the variety of styles, how this case can be handled. So yes, do your duties properly, attend the emergencies properly, don't skip away from your job. That is what we want. And sir, how we can keep armed guards in India? Can we get a license? Armed guard? Oh, Shiv, then that's a two-name question. It's not necessary. Always remember, doctors are good, patients are good. It's always there may be once in a while, you can say, get acclimatized or you get acquainted with those, you can say, unfortunate events. In that case, you have to be smart enough to run away from that. Forget about everything, run away from the scenario at that time, rather than boasting of your power or the rightness, because everything can be justified in court of law, but not in front of crowd. So yes, if you don't have armed guards and this and that, how to handle the chaos before the chaos happens. Always have a sense that something bad can happen. You are being loved by a lot of people, and yes, don't take it on ego. You will save people, you will treat a lot of people, but right now it's not time to argue with them, because they are heated and enraged because of their loss. So yes, as the time will pass, 24 hours will pass, they will get settled down. You have a lot of options. So don't have a direct verbal or any physical altercation with the patient. उनका हाथ टूटेगा, कुछ नहीं जाएगा. आपकी 2 उंगलियां टूट गई, आपकी पूरी लाइफ खराब. So yes, this is what you have to understand. Sense when something fishy is happening and run away from that scenario. I'm not called you a coward. I will say that you have done a job of wisdom. This is not cowardness. You are wise, because if you're not wise, you'll not be able to continue with this phase for a long time. क्योंकि हमेशा ये सब चीजें होती रहेंगी, because if you have not faced complications in your life, that means you are not a surgeon. Okay, Vivek has asked one more question. What is the criteria while choosing the college for general surgery for KGMC और लखनऊ? बच्चे कुछ भी चूज करो, सबसे पहले तो ये होना चाहिए कि लाइसेंस सीट होनी चाहिए. दैट इज permitted seat versus a registered seat. There are a lot of places where the seats have been recently permitted. What happens, suppose if you are from Bihar and you go to a college in UP and take admission on that permitted seat, definitely permitted seat will get registered over the time. But until unless it doesn't get registered, there are some medical councils who create some problems. So पहली चीज है कि जो सीट प्रेफर करो कि permitted seat ना हो, वो registered seat हो. दूसरी चीज है, try to understand that your me time is also important. When you talk about your me time, that means when you want to go to a family, meet your friends, there's a function, there's a marriage. Suppose I'm from Delhi and I have taken a medical college, I've taken a college in Guntur. So यहाँ से पहले मुझे फ्लाइट एक्सेस बड़ा मुश्किल है मुझे दिल्ली आने में, तो मेरा आने जाने का टाइम इतना बढ़ जाता है कि वो मेरी ना वो 3 साल बहुत खराब चले जाते हैं. And then second is, if you want to settle in Delhi, try to choose a college which is near to Delhi. Because here, the more frequently you visit, the more the people will acknowledge कि ये हमारा डॉक्टर है. This is the sense that people have कि ये हमारा डॉक्टर है. So try to understand. Yes, don't be egoistic until unless you're getting a very good college. Otherwise, try to take a college which is as close to your center as possible, your home. And then tier 1 cities, any college is good. Try to take them first, then only go for tier 2 or tier 3 cities. Tier 3 I think don't have a college, but tier 2 cities do have a college. So बहुत सारी चीजें important रहती हैं in choosing a college wisely.
Sir, another doubt what we all have is while choosing a college, like hands-on experience, like in tier 1 or tier 2 cities, like how will that affect us our career in the long
No, try to understand hands-on is just a matter of 6 months. First thing is the knowledge. So take a college where academics are good. Always remember, a college where you have good academics, you'll always go long. If you don't have good academics, you'll always long for those academics once you pass out. Hands-on ki rahi baat. So if you are from any college, you'll get residency, or when you are into the residency, all the word is yours. Government college में 6 महीने में सब कर लोगे. Like I passed from a college which is known as IPGMR and SS camp, and there are a lot of people when I was trying to enter, लोग कहते थे वहाँ पर MD surgery होती है, MS surgery नहीं होती. And you know what surgery I don't do today? I do every surgery. वहाँ पर लोग कहते हैं ना cutting नहीं है. अरे you are, first of all you have to understand you're a surgeon, not a butcher. You have to learn the attitude of the branch, which is more important, because this is the thing which you will not get from any other college. Rather than taking a peripheral college, we are doing 100 open cholecystectomy. It's better to go to a college where you see 100 cholecystectomies, 100 lab CBDs, 100 Whipples, 100 colorectal cases. Because एक बार देख लोगे ना तभी मजा आएगा, नहीं तो फिर वो YouTube से देख देख के सर्जरी सीखोगे. So ये बहुत जरूरी चीज होती है. वो कटिंग फटिंग को अभी ध्यान मत दो. Every college, if they have a surgery department, they will show you cutting. You'll get some hands on. और उतना हर एक को मिलता है.
Okay, sir.
In quantity.
So, can you just give us a difference in DNB versus MS surgery? So
There is no difference. There is no difference if you're doing it from a good surgery. But DNB becomes a hell if you do it from a private hospital, because you are just like a qualified registrar. You don't get any hands on. You keep on dressing the patients. पेशेंट लोड इतना अच्छा होता नहीं है प्राइवेट हॉस्पिटल्स के लिए. मैं बात करता हूँ अपोलो मैक्स या कहीं की भी बात करो, वो ना फ्रस्ट्रेशन आने लगता है, शुरू होने लगता है, because you don't get a lot of good cases. It all depends upon a good consultant. If you are lucky, you have a good consultant, he will show you cases. I'm not saying all the private DNBs are bad, because very soon I will be starting a DNB at my own hospital also. So I will definitely try it that once a student has come, I'll personally take a interest to teach, because we already have residency program running in my hospital. There are a lot of laparoscopic training programs, fellowships, diplomas program, masters running. So मेरे लिए वो फर्क नहीं होगा. पर everyone, every surgeon, is he or she interested to teach the juniors? That is the way. So one thing, that the level of harassment that you might acquire in a private hospital in DNB, otherwise DNB and MS are equivalent. Everywhere if you go, there is no problem with that.
Thank you, sir. Sir, one more thing, like, so is there any gender bias that is happening?
Not at all. The surgery is getting more delicate and more precise. If you say orthopedics, I will not say. But here the surgery is getting more precise. Laparoscopy, uske baad robotics. We need fine movements. And females can have a better fine movement. The only problem is that they think that this is the male prototype work. ऐसा नहीं है. So females ले रही है, अच्छा कर रही है.
So thank you, sir. Sir, is there any special message or something which you would like to tell to the students?
I'll just end the conversation with a small thing that you people, if you're planning to choose surgery, think it that this is an asset that you are buying. You are investing your time in an asset. Don't try to compare surgery with anything else if you want to be a surgeon. If you want to be a surgeon, you should not be having a second thought about surgery. Rather, you should be having a motivation, a strong motivation to become a surgeon. Remember, your time will also come. Everyone will be a good surgeon one fine day if you have the faith in your branch. Otherwise, if you don't have the faith in your branch and your brand, you'll never be a brand. So take my words, it's a wonderful branch. You can confidently take it, and you will not regret after maybe 50, 60 years when you are taking the last few gasps of your life, and you will feel when you are getting a bit drowsy and you are just trying to notice that there's a transition between your soul and the extra word. That day you will feel that yes, this is what you used to do every day, and a patient used to come to your table that anesthesia, the general anesthesia. Now this time you're having your own surgery, you're yourself on that table, and you will get sublimed into the word which you actually wanted to enter. So this is what I think about. Like whenever I see a patient going into that eternal word, I also think that one fine day I will also be on this table and I will die peacefully as a surgeon. So that motivation to become a surgeon is more important than anything you get.
Saurabh sir, it's a great pleasure and honor to be, to be interviewing you. And thank you so much, sir, for giving us this time and lot of information. Like even though we asked question, you give us a lot of more information that we have never been aware of. So thank you so much, sir, for spending your time with us.
Thank you everyone, and it was my pleasure. And anytime you want to meet me, you want to learn anything from me, it's my hospital is always open for you people, and I'm always overwhelmed to be a part of any academic program, any you can say interviews which actually can change the life of the students. So it was a pleasure for me for interacting, and thank you for inviting me on your platform. Thank you. Continue the good work that you people are doing.
Thank you, sir.